Hello, my name is Pete Sloane. I'd like to welcome you to the first session of Pulmonary Academy. This first series of 10 sessions will focus on the world of outpatient pulmonary medicine. Let me share a little bit about myself before we move forward. I am board certified in internal medicine, pulmonary medicine, and critical care medicine, and have been in practice in Baltimore, Maryland since 1991, with a focus on teaching and training medical residents and students. I'm a graduate of Cornell University Medical College and underwent my specialty training at Thomas Jefferson University Hospital in Philadelphia. Some of my teaching appointments, leadership positions, and teaching awards are listed here. I have no conflicts of interest or financial disclosures to report in relation to this program. First, a few words about the course. This course evolved from an educational void recognized by Dr. Brian Bonner, a partner in practice with me at PCCAB. PCCAB is a large pulmonary critical care and sleep practice out of the Baltimore and Central Maryland area. In addition to caring for patients in the hospital, we take care of pulmonary and sleep patients in 4 outpatient offices. We have 24 physicians and over a dozen advanced practitioners caring for our patients in both the inpatient and office setting. Our advanced practitioners see most of our follow-up patients entirely independently, although physicians are available to help if needed. We have heard time and time again from our advanced practitioners, whether new to the outpatient world of pulmonary and sleep medicine or seasoned veterans, that there is no one good place to go for an overview of pulmonary and sleep medicine as it pertains to the outpatient arena. With this series on pulmonary and the companion series by Dr. Bonner and sleep, we hope to fill this void. If you complete and enjoy this series, I encourage you to move on to Dr. Bonner's excellent sleep series. Each of these sessions will be broken down into a few bite-sized parts covering one key concept or topic. The intended audience includes advanced practitioners, medical students and residents, respiratory therapists, and anyone else seeing patients in the pulmonary outpatient setting. My approach is to start with fundamentals and framework, apply these to disease states and real clinical problems, and have you work with me to solve these problems in an interactive format. At the end of each session, you'll have a chance to take a post-test and, upon successful completion of that session, obtain CME credit as applicable. Before we jump right into today's session, let me show you how the session fits into the 10 sessions that make up the series. In this first 4-part session, I plan to cover the fundamentals of pulmonary medicine that will be useful to you throughout the course and in the real world of pulmonary medicine, whether in the office or hospital. I will cover normal physiology, the 5 physiological mechanisms of hypoxia, overview acid-base disorders, and finally, review the basics of how we classify lung diseases. In the subsequent 9 sessions, I will cover pulmonary testing, the approach to pulmonary office visits, lung disease states including obstructive, restrictive, vascular, and neoplastic diseases, and several other topics that I hope you will find interesting. Let me take a minute to review the learning objectives for Session 1. By the end of Session 1, you, the learner, should be able to recognize the primary and secondary functions of the lung, identify the basic anatomic lung units, distinguish the 5 causes of hypoxia, recognize single acid and double acid-base disorders, along with classifying lung diseases into 4 major groups. So now let's get going with Part A of Section 1, a discussion of normal pulmonary physiology. The primary function of the lungs is gas exchange, that is, oxygenation and ventilation or removal of carbon dioxide from the blood. Other functions of the lung include immunologic functions such as immunoglobulin secretion and regulation of blood pressure, such as angiotensin converting enzymes' role in the lung to convert angiotensin 1 to angiotensin 2, a potent vasoconstrictor. The lungs also act as a filtration unit, keeping venous clots from the systemic circulation. I'd like to discuss the nomenclature of the lower respiratory tract, that is, airways below the level of the vocal cords. The airway is divided into two zones. The more proximal, larger airways form the conducting zone, whereas the more distal, smaller airways form the respiratory zone. What distinguishes these two zones is that only the respiratory zone, which contain alveolar units, participate in gas exchange of oxygen and carbon dioxide. For that reason, as we will see when we review normal lung physiology, air that fills the conducting zone at end inspiration and then is exhaled is part of the wasted ventilation known as anatomic dead space. Healthy lungs are marvelously efficient at promoting exchange of oxygen and carbon dioxide between the air we breathe and red blood cells that carry about 99% of the oxygen in our blood. This is accomplished by spreading the blood out over an incredibly large surface area of contact at the alveolar capillary membrane interface by an amazing branching network of airways and blood vessels. Starting at just below the vocal cords with the trachea, which is about 2 centimeters in diameter in the average-sized adult, the airways divide into the right and left main stem bronchi, then lobar, segmental, and subsegmental bronchi. Bronchi are so large that they require cartilage for support. They also contain submucosal mucus glands. The smaller conducting airways are known as bronchioles. Bronchioles do not require cartilaginous support and no longer contain mucus glands. The initial 32 or so bronchioles branch about 10 or 12 times until there are around 60,000 small caliber bronchioles. Next, the bronchioles continue to branch, but now, for the first time, their walls include alveolar elements. At this point, since the bronchioles participate in gas exchange, these bronchioles are termed respiratory bronchioles and mark the beginning of the respiratory zone of the lung. Next, the smallest branches of the respiratory bronchioles form the alveolar ducts, tiny airways that are completely formed from alveolar units. Finally, the ducts end in alveolar sacs, which are truly the business end of the airways where the majority of gas exchange takes place. In summary, a single trachea measuring 2 centimeters in diameter branches a total of about 23 times through a conducting zone and into a respiratory zone comprising 8 million alveolar sacs and 600 million alveoli measuring 200 microns and covering a surface area of 7 square meters. I'd like to review some healthy lung pathology with you. In the first frame, we see a healthy appearing bronchus with cartilage, some stroma, the epithelium lining of the lung of the bronchial surface, and the lumen. This more close-up view shows some mucinous glands within the stroma, smooth muscle, cartilage, epithelial lining, and over here the luminal side. This is a terminal bronchiole, going into an alveolar duct, which is entirely lined by alveoli. And finally, the end of the road is the alveolus with the air spaces and the interstitium with its capillary network. Let me zoom in on this interstitium here a little bit. So we start with the air spaces over here, the alveolus, which is ventilated all the way from the mouth through the large airways conducting into the respiratory airways down to the alveolus. These are type 1 pneumocytes over here, which are the main lining cells of the alveolus the epithelial cells. They spread out and create the membrane. A larger type 2 pneumocyte is a surfactant-producing cell and also a regenerator cell for any lung damage that occurs at the alveolar level. The interstitium is the space within the lining of the lung that is part of the separation between the air spaces and the capillaries. The epithelium forms part of the barrier between air and blood. And here's a lung capillary with some red blood cells in it. This green is really the three sections of the interface: the alveolar epithelium, the interstitium in between, and the capillary endothelium. This interface right over here is what oxygen has to cross from the air into the blood and what carbon dioxide has to cross on the way out. So let's discuss determinants of tissue oxygen delivery. An average-sized person consumes about 250 cc's of oxygen per minute. Oxygen is delivered to the tissues at about 1,000 cc's per minute, so that 25% of the oxygen delivered is extracted by tissues. This 25% is called the extraction ratio. How does oxygen get delivered? Cardiac output times blood oxygen content, that is, cardiac output times blood oxygen content equals oxygen delivery. For example, if we send 5 liters of blood per minute to the body and each liter contains 200 cc's of oxygen, then we've delivered 1,000 cc's to the human body. Low oxygen content can be compensated by increased cardiac output. Let's discuss determinants of oxygen content. Hemoglobin can hold up to 1.34 cc's of oxygen per gram of hemoglobin. Hemoglobin is the most important factor determining oxygen content. For example, dropping of hemoglobin from 14 to 7 grams will decrease oxygen content by approximately 50%. The hemoglobin oxygen saturation is defined as the percentage of hemoglobin containing oxygen. The oxygen saturation is the second most important cause of a low oxygen content after the hemoglobin level itself. For example, a typical fairly severe drop of oxygen saturation from 100% to 85% will only decrease the amount of content by 15%. Dissolved oxygen is the least important determinant of oxygen content. This is how much oxygen is dissolved in the blood not attached to hemoglobin and is measured as the oxygen tension, or PO2, in units of millimeters of mercury. Only about 2% of oxygen in the blood is in the dissolved form. The rest is on hemoglobin. Thus, anemia or low oxygen saturation will lower the O2 content. Let's discuss the relationship between oxygen tension and hemoglobin saturation, known as the hemoglobin-oxygen dissociation curve. At sea level, atmospheric pressure is 760 millimeters of mercury, and since oxygen comprises 21% of air, the oxygen tension at sea level is 150 millimeters of mercury. At the alveolar level, the oxygen tension is only 100 millimeters of mercury because some of the space is occupied by carbon dioxide, which is extremely low concentrations in the atmosphere but significant in the alveolus. Carbon dioxide here is a white dot with 2 green dots, representing carbon and 2 oxygens. So the trick here is to get oxygen to move across the membrane while carbon dioxide moves out of the lung from the membrane, from the capillary side of the membrane to the alveolar side of the membrane. In this example, the alveolar oxygen tension is 100, where the capillary oxygen tension, known as P arterial O2, is 90 millimeters of mercury. This tension of 90 millimeters of mercury is enough dissolved oxygen to create a saturation of 98% in the red blood cells. In this example, the difference between 100 millimeters of mercury in the alveolus and 90 millimeters of mercury at the capillary side creates a gradient of 10 millimeters of mercury known as the alveolar arterial or AA gradient. So how does O2 tension directly relate to hemoglobin saturation? In this last example, we saw that a tension of around 90 created a saturation of 98% right up here, but a common point on the curve is a tension of 60 is all that we need to create a saturation of around 90%. So the critical oxygen tension we strive for in critical care medicine and in pulmonary medicine is a PO2 over around 60 so that our saturations are into the 90s. Notice that this relationship is truly a curve. It flattens out at the top, so as the PO2 goes over 70, there's very little more oxygen carried by the blood, but when the PO2 goes below 60, the oxygen percentage falls off very rapidly. Also notice that the position of the hemoglobin oxygen dissociation curve moves to the right or to the left based on other factors such as a low pH, a high level of 2,3-DPG, or elevated temperature shifts the curve to the right, favoring unloading of oxygen off of hemoglobin. That makes sense physiologically. In the extremities, when the pH under stress is lower and temperature might be warmer, we'd like oxygen to have less affinity for hemoglobin and fall off of the hemoglobin, so that's what we call a rightward shift. 2,3-DPG is part of maternal fetal circulation, and elevated levels at the fetal side of the placental barrier favors oxygen coming off of hemoglobin into the fetal circulation from the maternal circulation. The shift goes both ways, so that elevated pH, low levels of 2,3-DPG, or low temperatures favors more stringent or tighter binding of oxygen to hemoglobin, shifting the curve to the left. So let's review a case to help us better understand determinants of tissue oxygen delivery. You just evaluated 4 patients, all male, approximately 70 kilograms and 68 inches tall, in the ICU that are all under continuous monitoring with a pulmonary artery catheter, oximetry monitoring, and routine laboratories. Which of the following would be expected to have lowest tissue oxygen delivery measured in cc's of oxygen delivered to the body per minute? Patient 1, who has a normal cardiac output at 5 liters a minute, normal hemoglobin at 14 grams per deciliter, and normal O2 saturation of 98%. Patient 2, whose cardiac output is low at 4, otherwise normal hemoglobin and saturation. Patient 3, whose hemoglobin is low at 8, otherwise normal cardiac output and saturation. And patient 4, whose saturation is moderately low at 85%, but hemoglobin and cardiac output normal. Let you think about this for a second, and I'll go over the answer. You could pause, of course. So the correct answer is patient 3, the patient who has a normal cardiac output but is moderately anemic at 8 with a normal saturation. This patient's hemoglobin is low by about 40%, so the oxygen delivery will also be low by 40%. The patient who has a normal hemoglobin but a low cardiac output at 4 will have a low oxygen delivery, but only down by 20% because the cardiac output is 4 instead of 5. Likewise, the patient whose saturation is 85% will have a lower oxygen delivery than patient A, but only by about 13% compared to about 40% for patient C. So again, a moderate anemia is much worse for oxygen delivery than a moderate oxygen desaturation. I wanted to thank you for making it through Part A of Section 1, and please join me on the other side. Part B of Section 1 will follow.